Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I am with Dr. John Holcomb. Welcome.
Great, Dennis. Great to be here. Thanks.
I really appreciate it. And the reason why I got you on the podcast is we heard you heard your talk with the JTS on TBI management and the use of plasma for the treatment of severe TBI. But since this is the very first time you're on the podcast, would you mind just doing a quick introduction of yourself?
Yeah, sure. So let's see. I'm a general and trauma surgeon, critical care trained. I was in the Army for 23 years. I retired in 2008, a long time ago. I did spend 10 years with the Joint Special Operations Command and their surgical unit and had the opportunity to deploy all over the world doing that. And then I made the unfortunate mistake of rejoining the conventional Army. Did that for about a decade. So since then, I've been at really busy trauma centers in Houston and in Birmingham, Alabama.
Right. Awesome. Well, you're definitely the dude to talk to. So if you wouldn't mind, if you would maybe just give the wave tops of the presentation, like why on earth would we want to be giving plasma to a traumatically injured, brain injured patient?
Yeah. So I think it's really important that we understand, and this comes from our previous discussions, that what we're talking about is not the shocked patient and the patient hemorrhagic shock who's bled a liter or two of blood. This is the patient with isolated TBI, right? And so what we're talking about is giving plasma as a drug, not as a resuscitative fluid to cure hypotension. It certainly will do that. It's actually very good. But we're talking about giving it as a drug, and we're talking about giving it as a drug almost preemptively to avoid edema. Right, when somebody has a severe, moderate or severe TBI, not mild, but moderate or severe, and they have blood in their brain, that's kind of called a primary injury, right? We can't fix that. I mean, if you have a baseball bat or a gunshot fragment wound or whatever, right, we can't fix that primary injury, but what we can mitigate and hopefully avoid is the edema that surrounds that to make the pressure worse. And maybe also prevent the expansion of the primary hematoma, right? And I will tell you, in my opinion, the data are pretty clear that plasma will do that, and nothing else will.
Okay, awesome. So, look, I'm not a neurologist. We figured that out. I've been talking for 45 seconds, and I'm sure everybody's figured that out yet. When it comes to preventing the swelling, preventing secondary injury, plasma has the same tonicity as blood, right? As like the normal plasma in their vascular system. Mm-hmm. So I guess I don't understand how we're going to prevent edema when we put the same tonicity fluid in there versus something like a hypertonic.
Yeah, so it's because of this thing called the Glycocalyx, Dennis, and the Glycocalyx is really the key. The Glycocalyx is a protein layer that lines every endothelial cell in your body. It also lines the choroid plexus, which is the part of your brain that makes the CSF. And so when you have an injury, the blood-brain barrier opens up. Now, the neurosurgeons and the neurologists faked this out for about a decade, because they call it a blood-brain barrier. The rest of the body, it's called the endothelium. It's exactly the same. It's the same thing. It's kind of funny that they changed the names. And the way we got to think about the brain is just another organ. It's just like the bowel. It's just like the lungs, the kidney, or the liver, or whatever, right? Now, it's an important organ. And the endothelium in the brain is different than the lung. But for those who have kind of studied this blood-based resuscitation over the last 20 years, we used to give lots of crystalloid, and we used to give lots of different things. And that caused edema in the bowel and the lung and every place else. We don't do that anymore, right? We don't give crystalloid, and what we see is there's no edema in the bowel or the lung or the kidneys or the liver. But we still give, some people still give hypertonic saline or saline to brain injury patients, and it causes edema. We were talking about increased ICP and herniation earlier. It is my opinion that if we give plasma instead of hypertonic saline or any of the other things, that will decrease edema and decrease ICP. You talk about decreasing ICP. Well, how about avoiding increased ICP to begin with, right? Let's avoid it. Let's don't try to decrease it. Let's avoid it. So giving plasma as a drug repairs the glycocalyx. That's a fact. We have very beautiful basic science data, mouse data, rat data, pig data, large animal data over the last 10 years, 15 years. And they're pretty compelling single center retrospective studies. And even more compelling is a secondary analysis of a prospective randomized study. I know we're kind of throwing out lots of papers here, but that's how this works, right? I mean, you have to know the why, right? People have to know the why. The medics need to know the why to do something, not just be told to do it. Now, I feel very strongly about that. When I was at JSOC, we trained a lot of medics, in the tier 1 assets. We did a lot of training, and we always did the why in addition to do this, right? You got to put them in your hand because you can't cover all scenarios. There's no way in a thing like this or in training evolutions that you can cover all possible scenarios, especially in a prolonged field care environment. So the goal is decrease edema, right? Decrease edema or never see edema. You translate that to the brain, and what that means is you never see increased intracranial pressure, right?
Oh, really? Does it work that quick?
It works very quickly. And if you give a product like saline, hypertonic saline, that does not repair the glycocalyx, does not repair the blood-brain barrier, then you're going to get edema because the endothelium or the blood-brain barrier remains permeable, right? And so fluid goes from the intravascular to the extravascular space. That's what causes edema. Plasma repairs the glycocalyx, decreases that permeability, keeps the volume, keeps the blood and all the stuff that's in the blood in the vascular system, and decreases extravascular fluid, decreases edema. That's really, it's actually not that complicated. We can go there's all sorts of molecular mechanisms at the glycocalyx endothelial level, but that's what it does. And if you kind of think about evolution, so we have about 2 liters of plasma floating around our body, right? And it has plasma has thousands of proteins in it. And what's happened over millennia is that, if you have a relatively minor injury and, 200, 300,000 years ago or whatever, then the plasma was floating around your body repaired that endothelium and you didn't get edema. Only in the last 100, 150 years have medics, kind of doctors, nurses, medics shown up with IVs or something and put fluid into patients and cause fluid to go the other direction.
Yeah, absolutely. I mean, and then there's that whole idea of like auto-regulation and auto-resuscitation, where the body actually pulls fluid into the vasculature to help increase perfusion.
The auto-resuscitation thing is key. It's actually part of my talk, a longer talk that I give. That comes from Guyton Physiology, which is the textbook I had in medical school. Talks about auto-resuscitation, and that's that fluid without resuscitation. These are animals now. People are just, different kind of animals. You have fluid going from the extravascular space to the intravascular space. And that's what causes that auto-resuscitation up to about 2/3 of the starting blood pressure, right? That's evolutionary pressure. That's a positive thing. What we want to do is work with that, work with the body, right? Work with the normal physiology. And if you give crystalloid, any kind of crystalloid, it makes it go the opposite direction and causes edema, right? If you give plasma, heals the endothelium, repairs the glycocalyx, heals the endothelium, and keeps the volume that you give intravascular as opposed to causing edema. And edema causes increased ICP, right? So I think that, we need to do a little bit more work, but I think that if we give plasma early as a drug, that will prevent increases in ICP rather than having to treat ICP. I mean, it's much better to prevent something than to treat something, right?
Yes.
It's much easier.
Absolutely.
Easier, right? It's easier. Yeah. That's the why, really. And does that make sense?
I mean, it absolutely makes sense. And I guess I don't know why. So when we first started giving blood, that made sense. We have red stuff leaking out, give them more blood, or stop the bleeding, give them blood. That works. I've been hearing about the Glycocalyx for about a decade.
Right.
About the importance of it. But still, and like I've pulled up several, brain trauma guidelines, traumatic brain injury guidelines, and almost all of them say you have a hypotensive, severe TBI patient, give them normal saline.
Right.
Now, me as a medic, that doesn't make sense. And I'm also not that smart. I would give them blood and not necessarily follow the guidelines. But I guess why do the guidelines keep pumping out like resuscitate with normal saline?
So I've gone in as diving into this area, I've gone and reviewed all the guidelines that I can find. And I've talked to the guys who write the guidelines. And one thing that's very clear about the TBI guidelines, they kind of most of them start in the emergency department or the neurointensive care unit. So there's not many neurosurgeons that carry rucks and go pre-hospital. There are not many neurologists that carry rucks and go pre-hospital. And so
no, absolutely not.
Most of the guidelines, and I don't mean that in a negative way, it's just that's a fact. Most of the guidelines don't really address pre-hospital care. And they certainly don't address prolonged field care, prolonged casualty care. When I talk to the folks who are on the pre-hospital brain trauma foundation guidelines, and when I read their papers, and this gets back to the silos that we're talking about the other day, previously, when you read the papers that they write, they talk about this injury to the blood-brain barrier. Right? They all say that this happens. What they don't talk about is how to repair the blood-brain barrier. And in the trauma world, emergency medicine world, the hemorrhagic shock world, we've been talking about how to repair the endothelium, the glycocalyx, for 15 years. And we've been very focused on that. When I teach surgery residents, emergency medicine residents, and medical students today, and by the way, at where I work, we teach all the PJs rotate through as well. I said, look, when we give blood, we are repairing the endothelium. We're repairing the glycocalyx. That's the bottom line. Now, and it increases the blood pressure and things get better and decrease edema in the bowel. It's exactly the same thing in the brain. So the people who write those guidelines have identified the blood-brain barrier as a problem, the permeability. What they haven't identified is how to fix it. And I said, well, if you just leave the neurointensive care unit and go to the trauma unit, we'll tell you how to fix it. Because we've been doing that for 15 years. And it is really focused on the edema. They're starting to listen. That dialogue is going right now. Now, the other thing is guidelines always lag behind clinical care. Kind of by definition. Guidelines they're not cutting edge. Guidelines don't lead the field. The field is led by individual institutions, that do multi-center studies and write papers. And then the guidelines follow.
And then textbooks follow about a decade after that.
Absolutely. Well, hopefully it'll get faster with, online textbooks. But yeah, there's a lag behind, there's always a lag where the guidelines lag behind cutting edge care, not necessarily standard of care, but certainly if you want to be at the leading edge, you don't rely on the guidelines to be the leading edge thing.
Yeah. No, No, but you do definitely use them to
Oh
save
yeah,
your butt if you make a mistake.
yeah, absolutely. Well, yeah, I've helped participate in doing guidelines for many years at the JTS, so I'm a firm believer in guidelines.
Yeah.
Yeah.
No, but talking about just giving plasma to anybody,
Mm-hmm.
my thought is, okay, well, I'm great. I'm going to heal the glycocalyx, but what is that going to do to his pressures? As a
Yeah.
medic,
So,
especially
yeah.
a combat medic, I know but one speed to infuse fluid, and that's time now.
Yeah.
Um,
Yeah. So I think it's a great question, and I think as we started off this discussion, for isolated TBI, non-hypotensive, you're given this as a drug, right? And I would, how fast to give this? Number one, you don't need to give it fast. You don't. The patients aren't hypotensive. It may have 20 cc's of blood in their brain, right? So it's not a huge blood loss unless it's a big scalp like that kind of thing. But yeah, so I would hang this and put a unit of plasma, which is 250 cc's, in over say 30 minutes. I mean, it's not necessary to jam it in the patient with hemorrhagic shock. And in fact, you probably don't want to, right? Because you don't want to raise the blood pressure too high. Low blood pressure is really bad for brain injury patients. We know that for a long time, but so is high blood pressure, right? There's that U-shaped curve that's really important. And you want to keep your patient kind of in that, at the nadir of that U-shaped curve, kind of the normal range.
right. So
Yeah.
a lot of the guidelines, at least the trauma ones or for the pre-hospital combat stuff, they always talk about like it's always a number greater than this, but they rarely mention, hey, like an end point. Like if his blood pressure gets to 140, stop. They always say like, hey, greater than a systolic greater than 100 or a systolic greater than 120. But rarely do they ever tell you, hey, if it gets to this number, like just stop.
Yeah, we're giving in several civilian EMS agencies giving plasma for TBI up to 2 units over an hour or so. Had no reported hypertension episodes. Now, will there be? Yeah, there will be. There's no question about that. And the blood pressure for a 60-year-old or 66 like me, and a blood pressure for a 20-year-old are two different things, right? So there's some judgment in there. And I think one of the reasons that some of the guidelines don't say a number is because you got to, the medics need to have judgment, right? But you have to teach, you have to understand the physiology. And maybe that's not the 18-year-old medic who's had 12 weeks of school, but certainly the paramedics and the more senior guys who've been back and forth and treated patients can understand, what hypotension is and what hypertension is.
Across the spectrum of patients, right?
Yeah, male, female, old and young, no question. Pediatric, on and on, right?
Yep. And like we just talked about, that goes into explaining the whys about stuff, not just, well, your book says or your protocol says or your whatever says, we'll just do that.
Yeah, a series of studies called the EPIC studies out of Arizona were really informative here. And they talk about hyper and hypotension. And they make the point that either one of those is really bad. The same thing with hyperventilation, by the way, out of the EPIC study. Really bad. Hyperventilation, should not do it. Does not help, right? Not only increasing the sodium does not help. It actually increases mortality. Associated with increased mortality, increasing sodium, which is what hypertonic saline does. So, the EPIC study, I think, has been very informative on some of these things that we've done, that I've done for a long time. Why did I do them? Because I was told to do them by my chief resident, right? And you start asking the why and reading some of the literature, and many of these things don't help, and in fact, sometimes hurt our patients.
You mentioned hyperventilation, and I see it still being taught.
Mm-hmm.
Where essentially just make one, I don't think they explain it very well because it's not nearly as easy to do as people make it out to be, but essentially placing a mask over the patient's face and just bagging real fast. And obviously, because the patient is hurt, they'll just comply with what is good, sound advice. What I think is different is actual ventilatory management, where you're actually measuring what the end tidal CO2 is and taking that to an actual goal. I think those two distinctions are not necessarily explained well.
Yeah. Well, again, the EPIC study recommended an end tidal PCO2 that was normal, right? That's if you hyperventilated to a low PCO2, the patients did not do well.
Right, and drastically too.
Yeah.
Also, something that we would also do with ICP, like we mentioned, hyperventilation, elevation, things like pain and anxiety, those also can increase ICP, increase blood pressure and things like that.
Yeah.
So, I'm giving this plasma, even though the plasma itself is a pretty small amount. I already have somebody who is pushing those pressures, right? They're already at, 130 systolic, 140 systolic. How do I calm that down to get them to a more normal area?
Yeah. If your patient is awake enough with their moderate TBI, right, to be experiencing pain, then obviously pain control is good. Ketamine is good. Does not increase ICP. That's a myth. And so a good pain control, however you want to do it, is a good idea. Elevating the head of the bed, if there's no worry about a spinal injury, I think is a good idea. That's what you do to decrease edema with a sprained ankle or whatever, so elevate the head of the bed. Keep that patient in their middle, the head in the midline. If you have a C color on, make sure it's not constricting the internal jugular veins, because that'll increase ICP. Those things are really easy to do, certainly in the hospital. A little bit harder to do pre-hospital, but can be done if you have time and you have one patient or minimal patients that you have to take care of. The volume that we're talking about, in my opinion, when given slowly, should not increase the blood pressure. All right, I'm not going to say won't. That's a pretty strong word, but should not.
And I don't mind. Belabor it like I'm stuck on it, but I understand not all patients are always, hypo or normal. Sometimes they're on the higher side. If I can move them to a more normal area using all of my tools, so much the better.
Absolutely. And that's the message, I think, from the EPIC study, is keep that blood pressure in, quote, the normal range, whatever is normal for that patient. Yeah. And use all your tools to do that.
Other than just volume going in, like you mentioned, 2 units of plasma. So that's a total of 500 mLs. Are there any other goals that I want to shoot for? Any other indicators that I'm succeeding? Or should I keep going with 3 and 4 and 5 units?
Yeah, I think it depends on obviously, to me, that now transitions into how many patients do you have? What's your evacuation plan? What's is this patient's neurologic status changing for the worse, or is it changing for the better? All those variables go into play. You know that better than I do. If you have multiple patients, I'm not sure I would expend all my plasma on one patient. A severe TBI is a big deal. With severe TBI, right? GCS of 3 to 8. Especially with lateralizing signs, very high mortality. Not 100%, but a high mortality. Probably right now we are using as a drug, not as a resuscitative fluid, and so you're not looking at a heart rate, blood pressure endpoint. Right now, the best data is with 2 units of plasma. Right, so probably 2 units, and I probably would stop there, especially if I had more patients to deal with.
let's say we're doing that. Things have been going okay. The patient has a seizure, the patient vomits, the patient, like something happens, their blood pressure spikes, and now it starts going down that road of that Cushing's triad. Would you still give a bolus of hypertonic just to stop that? Or would you just continue on with the plasma?
That's a difficult situation. What you're describing is a patient who is herniating. And in my experience, taking care of a lot of TBI patients over the years, both penetrating and blunt, when a patient is herniating, they don't do well. Nothing's 100%. But especially if you have other patients to deal with, I probably would not continue to treat that patient. And I might triage that patient as expectant, given, you have to know, again, evacuation time, number of casualties, etc. To me, that's kind of like blunt CPR, doing CPR on a patient with blunt trauma, in a prolonged care environment. That probably has a pretty low rate of return, and is extremely task saturated, right? Right. You hate to do that, especially if it's one of your buddies, but if you got two other buddies right next there that need, other things to do to save their life, I would move on. And I've done that, but, herniation, and there's no evidence that I'm aware of that hypertonic saline cures herniation.
No, I don't think it cures anything. Just from what I've read, it alleviates the symptoms for a time.
Yeah, but extremely briefly. And, would we do that in the hospital on the way to the OR to open up the head? It's done. Does it make a difference? Nobody knows. But that's what's done. But in a prolonged field care situation, or with multiple casualties and helicopters not coming in, and then even you get on a helicopter, you get a long ride to the hospital usually. And then you have to get to the hospital, then you got to get a CAT scan, and on and on and on before you get to a neurosurgeon to open up, or a general surgeon to do a craniotomy or craniectomy. Yeah, I think there got to be some reality there. Let's put some reality in and with physiology. And just because you can do something doesn't mean you should. And just because the guy is deteriorating in front of you doesn't mean that that what you're going to do is going to make a difference. Right? Those are tough conversations.
Yeah, absolutely they are. I was going to kind of remind me of just outcomes, right? And just in your conversations with different neurologists and neurosurgeons and et cetera, I'm sure you've had. I'm kind of confused how they delineate the outcomes of treatment and exclude that primary injury, if that makes sense. Like, a trauma surgeon, you have to amputate a leg. The outcomes were great. There's no infection. The patient's mobile, the daily activities of daily living have resumed, but they're not going to run again like they used to.
Yeah. So in isolated TBI, it's what's called a Glasgow outcome score. Not the Glasgow coma score, it's a Glasgow outcome score. And it really and it's determined at 6 months. And that's the outcome for TBI studies. And it's really based upon your functioning, can you get up and feed yourself? Can you walk around? Can you go to the bathroom? And that kind of thing. There's not many things that have shown improvement, to include hypertonic saline. Prospective randomized study published in, I think, the New England Journal of Medicine showed no benefit by Eileen Bulger, 13 years ago. Prospective randomized study, multi-center, pre-hospital, hypertonic saline, no effect on outcome, which is kind of the bottom line. Who cares about ICP if there's no effect on outcome, right? And so there is not a prospective randomized multi-center study of plasma today. There's actually one funded by the DoD that's getting ready to start. But there are highly suggestive, as I said, secondary analysis that show improvement in outcome and of prospective randomized studies. So pre-hospital randomized multi-center study, secondary analysis, so not the primary outcome, but the secondary of improvement, plus huge amount of animal data, right? And frankly, I do this in my practice today. If you come into my ED and you have a brain injury, I'm giving you plasma, right? I'm not giving you hypertonic saline or anything else. I'm giving you plasma to repair your blood brain. That's my practice today.
Okay. And then any kind of herniation, I'm guessing they're taking them up to get a hemicraniectomy or something like that.
Yeah, and hopefully, we don't have the data on this yet. Hopefully, by giving the plasma early, pre-hospital, instead of treating ICP, we'll prevent elevated ICP, right? Hopefully.
I guess observationally, have you noticed a difference?
Oh yeah, it decreases. Again, the brain is just another organ, right? It's just like the lung. We used to see tons of ARDS, which is edema in the lung. We don't see it anymore. We see tons of bowel wall edema, right? And bowels would explode out of the abdomen because of all the edema. We don't see that anymore. The young surgeons don't know how to do that because they've never treated, 500 open abdomens with bowel wall edema this thick. Because we don't get crystalloid to them.
No, we're definitely, almost none now. Now here's a weird one if you give any.
That's right. Yeah.
I
think the key is the brain is just another organ, and our whole goal should be prevent edema.
Right. Absolutely.
That's the message.
I don't know. Any final thoughts when it comes to plasma and TBI management?
Now I'm advocating plasma pretty strongly. I recognize that you got to keep it cold today, right? So never frozen liquid plasma is good for 26 days at 4 degrees centigrade. That's painful to do pre-hospital, right? The dried plasma is at the FDA. It's coming down the pike pretty quickly. We of course, have been saying that. Their first meeting when I was still in the Army was in 2006 with dried plasma, 2006. It's a little frustrating it's taking this long, but I do think there's going to be options available here pretty quickly.
Yeah, I want to say there's a company, Velco, that's in Texas, I think.
They're in Boston,
okay.
in Ireland, headquarters in Ireland. They have a branch in Boston, but they're at the FDA right now. Velco Medical. So in the meantime, figure it out. We've done it for a long time. You can figure. There are ways to carry pre-hospital plasma. They're not as convenient, but if I was carrying a ruck today, which I'm not, I would have plasma and plasma light in my ruck. Those are the two things. And I'd figure out a way to do the plasma and keep it cold. I would give it for hemorrhagic shock. I'd give it for TBI, isolated TBI. I'd give it for burns, and I would give it for sepsis, right? Now, and I would give plasma light because you can mix it with blood. I would give that for dehydration and diarrhea and whatever else the patient needed crystalloid for. Those are the two things I would have. I wouldn't have 4 or 5 things in my ruck, right? Like I did when I carried. It was crazy. And I think the guidelines need to take into account the logistics and what we're asking medics to carry and how much and what dose and on and on and on. I think if we can make it simple and effective, that's better for our medics.
Yeah, absolutely. Just one last quick question. You mentioned bringing plasma and plasma light. Would you not bring whole blood?
I would, yes. I would carry whole blood as well. But, so, there's cross-loading and mix and matching and that sort of thing. Yeah.
I just want to make sure I didn't hit my head.
Yeah.
Any final thoughts? I think I asked you a second time.
Yeah, no, I appreciate the opportunity to talk and great questions. And, this is the fun part of giving these talks is the questions that come about afterwards, actually. So I appreciate the opportunity. Thanks.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below. and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC Podcast, out.